So I'm going to look at global guidelines, a very quick overview. You're going to get a systematic review of those from Tosif and Sabrina, and that was put on late, and that's why Tosif has so many talks and Sabrina has so many talks, because I think that can inform our discussion this afternoon. And then really talk about using robust methods for reconciling the disagreements between the randomized trial evidence and the epidemiology, which is one of these examples that we have where the randomized trials really weren't lining up with the epidemiology, and having really a methodological approach that could help reconcile that. So those are my disclosures. David doesn't have any disclosures anymore in the last 10 years, but I was trained by David, so I used to have 3 pages of disclosures. So I cite all my disclosures, financial, familial, intellectual, in terms of guidelines I'm involved with too, where we've talked about sweeteners, across the board, different things. So what do the guidelines say about low and calorie sweeteners? And here we actually have a bit of a dichotomy, because the clinical practice guidelines really are universal. Those that have reported on the question, have done a PICO for low and no calorie sweeteners. All those that have asked the question, because that's always the case with guidelines, if they ask the question or not, but those that have asked the question and have issued guidance, all of them really are quite similar in that, insofar as they're replacing sugars as a way to replace sugars and displace calories. They are generally recommended across the board, including our new EASD guidelines, which I'll show you the work that went into that led to our recommendations. So this is to be juxtaposed, though, with the dietary guidelines, and Sabrina will be presenting a bigger snapshot, but just to give you, I think, 2 important framers of guidelines internationally, the US and WHO coming to different conclusions. So the US Dietary Guidelines for Americans coming to the conclusion that, and it was a change from 2015 to 20, where there was insufficient evidence, now suggesting there was sufficient evidence that low and no calorie sweeteners may reduce calorie intake in the short to medium term and weight management. But the WHO coming out in 2022, and Carlo touched on that and some of the reviews that went behind that, specifically, explicitly really recommending against the use of what they're calling non-sugar sweeteners. And that gets into what Alan was talking about, the different nomenclature, but really talking about the same thing, low and no calorie sweeteners, non-sugar sweeteners. What's important, I think, is you might ask, what's the difference? And we'll get into that a bit, but I think right off the bat, I think part of it is clinical practice guidelines tend to be driven by randomized trials, and a lot of the large dietary guidelines are driven more by the epidemiology. So this is partly getting at to why I think there are some differences, even though the dietary guidelines did consider the randomized trial evidence as well. Important too is the wording, and if you look at the WHO, I think one thing that stood out to me immediately and jumped out to me and it sort of informed our approach, and we talk about the importance of the comparator, is it suggested that they not be used as a means for achieving weight control or reducing the risk of non-communicable diseases. But what it's not talking about is what's the replacement. It's just talking about using these as if they were some sort of agent that's out in the food supply that we could take for weight loss, as opposed to that necessary, I would argue, necessary context of displacement of sugars and calories from sugars, in particular from sugar-sweetened beverages, where we hear the importance of that target from Karen and from Laura's talks. So why the disconnect? Well, we participated in this, but we're not alone. There have been many letters, editorials, commentaries, consensus statements. I was on one with Carlo and others that really called, I think, for stronger, more robust methods in this area. In particular, some of the randomized trial evidence in the beginning was quite inconsistent, and that was as a result of the nature of the comparator. Obviously, a lot of the trials that we have had placebo or water, and if you're comparing a low-calorie sweetener to placebo or water, you don't get displacement of calories. You wouldn't necessarily expect to see weight loss. To say that there's a null effect is completely expected, because those would be positive controls. So the nature of the comparator being important when really interpreting different study designs and what you get from the randomized trial evidence. And then in terms of the observational evidence, really this big 5,000-pound, I'll take Walter's quote on this, gorilla in the room, which is this issue of reverse causality, and which is touched on very nicely too by Carlo. And residual confounding and other sources of bias in the estimates that need to be considered. But really an important one here, and this is one that's in epidemiology textbooks, and I teach in my course and others, is a great example of an issue of reverse causality, and particularly relates to weight outcomes. Despite that, the WHO did commission reviews, and they came out with guidance in 2022, and this is just to give you the evidence synthesis from their commission review in 2022. This was the second one. They actually threw out the first one that was run by Jörg Meerpohl's group, because they didn't differentiate by the nature of the comparator. And we actually had discussions with Jason Montez and others that did the the synthesis to really get at the importance of looking at comparators. So they did do that in looking at the randomized trials, which I think cleaned up some of the evidence, but really not really paying much attention, although acknowledging it to the reverse causality. And so their own assessment was reverse causality was an issue. The certainty of the evidence was very low as a result. You had low to moderate certainty for the trials, but the conclusion still persisted that recommend against non-sugar sweeteners. And the reason for that, and they've given it here, is the discordant results. So this is a case, again, where we have discordant results between randomized trials and large cohorts, and giving more weight to the evidence from the prospective cohorts, acknowledging that the randomized trials do show a benefit, especially when displacing sugars and calories from sugars, but that the long-term nature of those prospective cohorts, that the great data that we get from the Harvard cohorts and others, really creating a note of concern and then leading to them to overweight that, suggesting that those short-term effects may not persist over the long term. And I know David asked about this and others raising this issue of what are the long-term effects and can we use the randomized trial evidence? So really siding with the longer-term evidence, even though it had many issues they acknowledged, but being on their prioritized outcomes, those big patient important, public health important outcomes like obesity, diabetes, cardiovascular disease, cancer, as was reviewed, seeing those signals, and so giving them more weight. So how does one reconcile the evidence? Well, we were actually confronted with this question when we were developing, and this was before WHO came out. Ours came out around the same time, a year later. The same year, 2023, was their updated evidence. Their synthesis was in 2022. We were confronted with this issue of the nature of the comparator trials and reverse causality. So our guidelines committee, when we were updating the EASD guidelines, which were just published in 2023, really came to the decision to do some methods development to try to deal with these major issues as we saw it in the literature, to try to come to a better sense of, better estimates of the impact of low and no calorie sweeteners. And this was included in our carbohydrate intake and diabetes management chapter of our guideline, and many in the room were part of the overall guideline. So this was the approach that was used. We use GRADE, which is the same thing that the WHO used. It starts RCTs off at high and prospective cohorts, our best designed observation studies, as low, but it allows for upgrades for magnitude of effect, dose response. So a lot of cases you're able to get that observational study evidence, like for sugar sweetened beverages and others, up to a higher level. But this was just to understand the framework, the evidence-based framework we used. It was led by some really capable students. So Tosif Khan, who you've heard from, and we'll hear again from, led the methods development. And then we had Naima McGlynn, a really great MSc RD student that we were very fortunate to have, that did the randomized trial evidence. Then Jen Lee, who's now on faculty at Toronto Metropolitan University, who did this just around the time she was starting her PhD with Mary LeBay. And so she's no longer a candidate, sorry, she has her PhD and she's now on faculty. So what is the evidence from randomized trials? So to answer this question, we really wanted to start with the framing of the question and framing it in terms of really clinical and public health important questions. So again, that nature of the comparators. So it's low and no calorie sweetened beverages for sugar sweetened beverages. So we call the intended substitution with energy displacement. Water for sugar sweetened beverages, which we called the standard of care substitution. All the guidelines are really, I think, are harmonized, and we would agree that water would be the first choice and represents the standard of care with energy displacement. And then to really get at that comparison between these two alternatives, if you like, low and no calorie sweetened beverages versus water, the reference substitution, so without energy displacement. So two of them with energy displacement, I think it's important to follow the energy here, and one without, which is the low no calorie for water. And Walter showed that in the updated analysis that was led by Alan Espinoza, that really nice work in advances in nutrition. So I'll show you first the intended substitution. So I've kind of set it up very similar to the way Walter did on his slide. So these were 20 pre-specified intermediate cardiometabolic outcomes. They were pre-specified by the guidelines group. They were throughout all of our commission systematic reviews and analyses on different questions. So these were here for low no calorie for sugar sweetened beverages. And what we see here, when we look at, again, take into account the nature of the comparator, when you look across these 17 RCTs, and I should say too, we use network meta-analysis. I skipped over that to really increase the information size because we don't have a lot of direct comparisons. So we wanted to be able to leverage those indirect comparisons and increase the information size. So when we did that, we did see what you'd expect in displacing calories and a reduction in weight-related outcomes. So we got reductions in body weight, BMI, body fat, and liver fat. And overall, I think importantly, no adverse signals across those 20 different intermediate cardiometabolic outcomes, but improvement in weight with energy displacement. Standard of care substitution for water. The editors were a bit surprised, and reviewers, and so were we, but I think we don't have a lot of pairwise comparisons here. We didn't see any benefit for water per se, but certainly no harm, and it's still a priori was our standard of care. That was just the evidence at that time. I suspect if we had more, we might see more, but in a lot of cases, asking people to switch from sugar-sweetened beverages to water can be a bit difficult if they're expecting sweetness, and so this could also be an adherence issue, which I know keeps coming into nutrition trial design, but not seeing any harm. And then I think importantly, when we look at the reference substitution, the first is to say we didn't see any adverse signals, but we did see, and that's the red and the green here, that in some cases, the low and no calorie were a bit better than water for body weight and for systolic blood pressure, but both in the direction of reducing body weight and systolic blood pressure, just a bit better for low and no calorie. And then for HbA1c reduction, the water was a bit better, but both reduced it. It wasn't that there was an adverse signal. It wasn't that they were increasing. I want to make that clear. It's just one a little better than the other a little better than the other one, and overall no harm. So I think our conclusion from this really was that, taking into account the nature of the comparator, that they do have the intended benefit of displacing calories and leading to weight related outcomes, intermediate outcomes, very similar to water, which would be the standard of care. So that was our conclusion, and that informed the guideline. Now, what about the observational evidence? Well, here we have this issue versus causality that was introduced by Carlo and by Walter, where people that are at risk for obesity, diabetes, these cardiometabolic diseases may be using low no calorie beverages as a mitigation strategy. So it's not that the low and no calorie sweetened beverages per se are causing the disease. It's by having the disease it causes you to select these as a mitigation strategy. And we took a look at the literature and some of the methodological papers from the Harvard group looking especially around weight outcomes, around prevalent exposure, lag change, and Walter sort of suggested that the best evidence from that was to use change analyses. So we wanted to look at change for change. That was one approach. The other was substitution analyses where they've been done appeared to mitigate some of the issue of reverse causality, giving you more biologically plausible, more aligned with the RCT evidence type signals. So doing that, and then the importance of really adjusting for baseline adiposity, where that might lead to some of the reverse causality. So pre-specifying those designs and looking again at those same three substitutions of clinical and public health importance. So low, no calorie for sugar-sweetened beverages, we're calling the intended substitution, water for sugar-sweetened beverages, the standard of care, and then the comparison between the two, which we're going to call the reference as the substitution models, and then the change. And this was published in Diabetes Care and led by Jen Lee to inform the guidelines. So unlike what we saw in the WHO commissioned review, where you saw a lot of signals of red, and that's really the case where you're seeing very similar signals to sugar-sweetened beverages, you're actually seeing increased risk and with the prevalent exposures. Here we saw results that aligned with the randomized trial evidence. So instead of seeing increases in body weight, we saw associated reductions in body weight, reductions in obesity incidence, reductions in CHD incidence, CVD mortality, and all-cause mortality. These are obviously big patient-important, public health important outcomes. So definitely prioritized outcomes. Seeing that, just a word too. I just wanted to say we pre-specified also looking at low and no calorie for sugar-sweetened beverages because of the knowledge we gained from the analyses of sugars that sugar-sweetened beverages are really the main target and the most important source of added sugars in the diet. But low and no calorie sweetened beverages are the most important source of low and no calorie sweeteners. They also get at, there's a heterogeneity that comes from, and this was touched on by Laura and others, when you're using low and no calorie in a solid situation, you're replacing gram amounts of sugars with milligram amounts of sweeteners, so necessarily you have more refined starches, and so the calories don't always change. Whereas in the beverage format, you do get complete displacement of sugars and calories because the bulking is water, as Alan said. It's just we're not getting those others. So those were reasons that we really wanted, I think, to take more of a scalpel to this to really refine and isolate the question so we could get at the signal. And so I still think it's probably the best way to look at low and no calorie sweetened beverages. And the other point to make here is that the most common sweetener, and this is important because Walter said this with the introduction in 82, is aspartame. So if we look across the food supply in Canada, internationally, and this was looked at by Sabrina for our trial that we're looking at, that we did the Stop Sugars Now trial, pragmatic trial, about 90% of the low no calorie sweet beverages, even 95% of the market, are sweetened with aspartame and ACE-K. So you don't see a lot of the other sweeteners. There's a minor amount that have sucralose. Sucralose you'll find more in yogurts and tabletop. So this really represents, if you're thinking about the sweetener, an aspartame, and ACE-K signal. But we're seeing that. So that's what that substitution. If we look at the standard of care water, here we're seeing some nice signals that we'd expect in the right direction now. We see reductions in body weight, waist circumference, percent body fat, incident obesity, and type 2 diabetes incidence. These are just the outcomes available. We would like to be able to look at more, and Tosif will talk about our Mega Cohorts project, which updates all of this. So both going in the right direction, and we look at the comparison between the two. There's some imprecision in some of the estimates, like for obesity, but you can see here no differences between water and low and no calorie sweetened beverages. So getting at that reference substitution, suggesting that it's behaving similarly to water in terms of and having the intended benefit. If we look at the change analysis, here we're much more limited, and you can see even the cohort comparisons are limited because a lot of this comes from the Harvard cohorts. Not a lot of cohorts, because of funding and design, have those repeated measures that are so important for looking at change for change. So it is a bit limited, and this really more or less is a Harvard signal at the time that we looked at this. But you can see here, looking at change analyses, we see a reduction in body weight. So when you look at prevalent or baseline, you see an increase. If you look at change, you see a decrease, and that agrees with the substitution analyses. So it just gives us more confidence in what we're seeing, and an associated reduction in waist circumference. So overall, we were able to get a good agreement or alignment between the RCT evidence and the prospective cohort evidence by really pre-specifying some more robust methods. So is there a WHO precedent? I think this is important. I raised this yesterday for looking at substitution. So the WHO themselves have taken this approach to saturated fat. So the 2015 commissioned review by Russ D'Souza and colleagues failed to show an association across their prioritized outcomes of saturated fat with those outcomes, but Russ made it very clear in the discussion that it's important to look again at the replacement nutrients, and really they didn't have the amount of substitutions or the methods at that time to be able to model that in this WHO Commission review. As a result, the WHO really sort of was slow to issue guidance, and it took them 8 years, and they finally updated that systematic review and meta-analysis, and it was led by Andrew Reynolds, who we know from the carbohydrate report, but he updated it, and Russ was part of this too, in 2023, where they did the substitution analyses. And when they did the substitution analyses, here you saw that substituting plant-based PUFAs and MUFAs, high-quality carbohydrates for saturated fat, you actually see associated reductions across the prioritized outcomes. I appreciate it's a bit small, but you'll have to trust me. So it really took a lot of those same outcomes and was able to show associated benefit of reducing saturated fat. So I think there is a precedent. The WHO themselves have used it, and I think it does represent the best approach. So how do these estimates compare with prevalent? And this is just to show you Tosif Khan's paper that we did afterwards, just to lay them out. So you can see where you're using prevalent or baseline exposures, it's all red, generally red or no association. But when you do the substitution or change analyses, you tend to see estimates that agree with the randomized trial evidence. And this was really just a call to really embrace the use of substitution and change for change analyses when trying to answer this question, because of this almost intractable issue of reverse causality, which we're able to get past a bit with these methods. So how do we reconcile the biological mechanisms? I don't have time to go through all of this, but I just want to say, like, part of this is this signaling of sweetness, and we've heard a bit about this. And a lot of concern was raised about cephalic response, other response, that these sweeteners, because of the uncoupling of sweetness with calories, that leads to signals, which may lead to increased intake. And so we did through IFINS, this was a competitive grant that we got to do this. We did a systematic review and analysis of the acute feeding trials to look at this uncoupling hypothesis that had been proposed, the uncoupling of sweetness from calories, delayed coupling, where it's given before a meal, and together with the meal, which we called coupling. I'm just going to show you the uncoupling because all the results were the same. They were really null, and I don't really have a lot of time to go through it. And we used, importantly here, network meta-analysis again to increase information size, because we thought it was important to bring that. So if we look at the uncoupling, this is a really busy league table, but I just want you to sort of orient you. On the left, you're going to have individual sweeteners. In the middle, it's blends, and that's the way it occurs in the market. So those are the blends of sweeteners. They often do not occur in isolation in products. Then you have water, and then you have your caloric sugars. And this is postprandial glucose. So as you expect, if you give glucose or sucrose, you see an increase in postprandial glucose. You don't see anything with the either the individual sweeteners, the blends, or the water. We pre-specified effect sizes because of the power here. You may see some small differences, and those were highlighted in bold. But we did pre-specify based on MIDs. So trivial would be less than 1, small important would be greater than 1, moderate would be greater than 2, large should be greater than 5, and very large would be greater than 10, a minimally important difference in postprandial glucose. You can see it's really driven by the caloric sweeteners, as you'd expect. They raise the sugars, the low and no calorie and water do not. This is for insulin, postprandial insulin, same thing. It's just the caloric sugars that raise insulin. We're not seeing these cephalic response on insulin per se of the sweeteners or water. Now we're losing data because it's just there's not as many trials, but same for GLP-1, same for, this is for GIP, postprandial GIP, the same for ghrelin, and the same for glucagon. And what I can tell you is it was the same whether we used a delayed coupling or coupling in people with diabetes or without. So we looked at all of that carefully because we thought that was important. So in terms of our conclusions from our work, the question of low and no calorie sweeteners and health outcomes shows the importance of accounting for the nature of the comparator, caloric versus non-caloric comparators, and the calories to be displaced. You have to follow the calories when we're talking about low and no calorie sweeteners for the appropriate interpretation of effects in randomized trials. And exposure assessment methods, so prevalent versus substitution or change for change models, and adjustments for adiposity for mitigation of reverse causality and residual confounding in observational studies. Our commission reviews, and we took these on board, showed improvements in the intermediate risk factors in the randomized trials, similar to water. And we found that that did translate and agreed that we had congruency with the observational evidence showing associations with decreased risk as opposed to increased risk for obesity, coronary heart disease, cardiovascular mortality, and all-cause mortality, again, similar to water. No adverse signals there. The findings are supported, I think, in terms of getting at the biological plausibility by some of the acute work that shows you're really not seeing that these are creating signals that might disrupt food intake regulation or glucose regulation across those. And the upcoming, and I didn't say this, I don't want to steal Tosif's thunder because he's going to talk about it, Mega Cohorts Pooling Project is going to apply these methods to the mega cohorts that are available through the Richard Dole Consortium to be able to reconcile some of these differences in evidence, I think, to really bring the best evidence forward. So thank you very much for your attention.